Hello everyone and welcome to MedLysis, where I summarize one article in less than 5 minutes. It's well established that ACE inhibitors reduce mortality in patients with STEMI when given within the first 24 hours of admission, but is one of them better than the others? To answer this question, we must take a look at impact of ramipril versus other angiotensin-converting enzyme inhibitors on outcome of unselected patient with ST segment elevation acute myocardial infarction, published in American College of Cardiology in 2002. So let's start lysing it. It's a prospective cohort study where 14,608 patients with STEMI from 217 hospitals in Germany were involved. Of those patients, 4.7% received ramipril therapy, 39% received other ACE inhibitors therapy, and 56.3% received no ACE inhibitors therapy. So sample size is adequate to detect any clinically significant difference. Clinical characteristics of patients were summarized in this table, which shows three groups: ramipril, other ACE inhibitors, and no ACE inhibitors with their respective p-values. There were no significant difference in age, gender, hypertension, diabetes, renal failure, and heart failure between ramipril group and other ACE inhibitors group because the p-values are not less than 0.05. However, patients on ramipril therapy received beta blockers and reperfusion therapy slightly more often than patients in other ACE inhibitors group. The table shows the same three groups: ramipril, other ACE, and no ACE. The hospital mortality of patients on ramipril therapy was 5.8% compared with 8.9% in patients on other ACE inhibitors therapy, with a p-value less than 0.05, which makes it clinically significant. In multivariate analysis, in which results were adjusted to 17 variables like age, gender, and other comorbidities, the ramipril therapy was independently associated with a significant lower rate of hospital mortality and non-fatal adverse coronary and cerebrovascular event compared to other ACE inhibitors group, but ramipril was not associated with a lower rate of heart failure at discharge because we know that confidence intervals, including 1, makes it non-significant, and the study had a confidence interval of 0.5 to 1.27 for the rate of heart failure at discharge. In Kaplan-Meier survival analysis, x-axis represents days after admission and y-axis represents survival percentage. We noticed that patients on ramipril therapy had a significantly higher survival rate compared with patients on other ACE inhibitors therapy or no ACE inhibitor. In subgroup analysis, we use it to evaluate how effective our treatment is for a specific outcome like mortality in specific subgroups. Subgroup analysis simply answers the question: does treatment effects vary among different subgroups or not? So in this study, hospital mortality and non-fatal coronary cerebrovascular event were the treatment effect, and the subgroups were age, gender, diabetes, hypertension, prior MI, and more. The reduction in mortality and coronary and cerebrovascular event in ramipril group versus other ACE inhibitors were present in all subgroups. Ramipril was associated with a lower mortality rate, lower non-fatal major adverse coronary and cerebrovascular event, but showed no benefit on the rate of heart failure on discharge. If you're convinced that ramipril is better than its brothers, then you might change your mind, because in this retrospective cohort study with 5,408 patients, is ramipril really better than other angiotensin-converting enzyme inhibitors after acute myocardial infarction? That was published 4 years later, showed no significant difference between ramipril and other ACE inhibitors. Well, ramipril, you're not that special after all. Let me know in the comment which ACE inhibitors you guys usually prescribe in your hospital. Thank you for watching, and I hope it was useful.